we've started the day. We've gone head to toe. Our sixth multidisciplinary clinic and program is the GI cancer program. Again, we are lucky to have two outstanding navigators, which help patients get to where they need to go. This program in the last 18 months has exploded, and it's due in a large part to many people. You're going to meet several of them during our panel discussion today, as well as our keynote speakers. The program is really based on anatomic location. And so, the GI system goes, basically from top to bottom. And so we actually have now expanded our tumor board in our clinic to accommodate the unique needs of what we call upper GI and lower GI. Today, we're going to be focusing on our lower GI team. We have our colorectal surgeons, which are based at Norton Women's and Children's Hospital. And then our medical oncologist, Dr. Nelson, will be discussing things. He's both downtown and at St. Matthew's. And then Dr. Altus, who is also on downtown campus. So I would like to invite Dr. Jones, our colorectal surgeon, to come up and discuss some things with us. So help me welcome Dr. Jones. Thank you, sir.
Hello, everybody. I am Ryan Jones. I'm at Norton Women's and Children's Hospital. I've been there for 3 years now, and I'm one of 2 colorectal surgeons that Norton has there. So I wanted to talk about rectal cancer from the perspective of a surgeon and when surgeons should be involved and why. So one of the main things that we always talk about is who are patients that we need to operate on. In patients with rectal cancer, it's people who have curative tumors that we can remove, also in colon cancer. So that means that there's no evidence of metastatic disease distantly to the main organs being the liver and the lung that we look at initially. We also look at patients who have issues such as obstruction, people who can't have bowel movements, patients with tumors who are bleeding and are symptomatically anemic. Regardless if they have metastatic disease or not, patients are typically going to need intervention, whether that be just a diversion with a colostomy or an ileostomy to keep from having completely obstructed the abdomen, or whether it be removal of the tumor for bleeding purposes. Now, one of the big trends in rectal cancer over the last decade has been the consideration for watching and waiting as opposed to proceeding with surgical treatment. These patients are ones who undergo what we consider total neoadjuvant chemotherapy and radiation. And there's going to be a lot more talk about these in the specific papers that are presented between myself and the other physicians up here. And typically what we look for is no evidence of any residual tumor in the rectum, that being main tumor or lymphadenopathy in the perirectal area, both radiographically on MRIs and also when we do endoscopic evaluations with a flexible sigmoidoscopy. For patients who have no evidence of residual tumor after undergoing treatment, we often will consider doing surveillance on these people with serial MRI exams, CTs, and with endoscopic evaluations. And over the last decade, we've seen there are a vast number of patients who are able to have cures even after 5 years of their rectal cancers, and this will allow them to preserve the rectum, which generally is a lot better quality of life. So one of the things that I wanted to touch base with on these initial studies are patients and their quality of life with rectal cancer. So one of the things that we look at from a surgical perspective is how bowel function is after we do surgery. Rectal surgery is notorious for causing multiple issues, including urgency, frequency, fecal incontinence, and as well as difficulty getting stool evacuated and feeling like you're able to have a good bowel movement. And these can be quite consuming for people's lives. It keeps them from leaving their house, enjoying activities, eating foods that they enjoy. And so this really has a significant impact. So the study that I'm talking about first is out of Memorial Sloan Kettering. It was published in Colorectal Journal this year. And it's looking at patients who have undergone the watch and wait approach to non-operative treatment of the rectal cancer and comparing those to people who underwent the standard treatment, which is considered a low anterior resection or removal of most or all of the rectum. So this is basically a study looking at people filling out surveys regarding their bowel function on a Memorial Sloan Kettering questionnaire that's been standardized. So when we look at these patients, it's interesting to note that all of the ones that are included in the study are people who don't have any evidence of metastatic disease, those who have no evidence of inflammatory bowel disease such as Crohn's or ulcerative colitis, because that puts them into another context. And it takes out anybody who had complications of surgery, which is one of the big things that we have to take into context, that Patients oftentimes will have some complication, whether that be symptoms or an infection or a leak or something like that. And so these are patients who in the study who did have the ideal situation and success with surgery. So the questionnaire that is given to these patients consists of questions in three categories regarding quality of life, which is what you can eat and what you have to avoid, how often you have accidents or urgency getting to the bathroom, how often do you feel that you incompletely evacuate. This goes for stool and gas. And so a combination of all these questions will add up to a score, with a 90 being perfectly normal bowel function. So looking at these patients, they all underwent total neoadjuvant chemotherapy and radiation. And in this study, everyone had FOLFOX for a total of 8 cycles, 2 weeks apart, followed by long course radiation. Both of those will be talked about later. So those who had a complete clinical response were put in the watch and wait category. And that meant that there was no evidence of tumor, both radiographically and on sigmoidoscopy. And the other patients underwent low anterior resection. This was not a randomized trial by any means. These were just propensity matched data. The patients who did undergo surgery had surgery in the standard time frame, 8 to 12 weeks after they finished their neoadjuvant treatment. And the surgeries were done both laparoscopically and open. So that did not differentiate in these patients. There were only a total of 28 patients in the watch and wait group included, and due to some exclusion factors, only 22 were used in the, 21 were used in the study. Now they were matched well to 191 patients and those who underwent surgery. So that way we can try to keep things balanced as far as age, gender, where the tumor was, what the stage was, and timing of therapy. So what this shows is the overall score after people either underwent surgery or had been at least a few months out from their radiation and chemotherapy, showed that the bowel function score was significantly higher in patients who we did not operate on. I think that is not too surprising. The less we do, sometimes the better things are, but this kind of proves it. And then this next graph kind of goes into more detail, showing within different categories that are involved, particularly with urgency and frequency. These are quite significant. Also in dietary choices, patients still were eating what they wanted, but there was still some improvement in patients who had less food fear. So one of the limitations was the small sample size. Again, I mentioned earlier, these were in patients who had perfect surgical outcomes and didn't have any complications. And so when you throw in that other patients do have surgical complications, that will definitely have a factor in quality of life after surgery. This is patients who were deemed as complete clinical responders in the watch and wait group. And we don't know that those who underwent surgery truly had a complete response. So the question about the patients who did not have a response was, did they have more aggressive tumors? Did they have other things that would impact their quality of life after? So those are some of the limitations. The next study I wanted to talk about is, okay, so patients that we do watch and wait and we go against the standard of care, which had been to operate right after doing neoadjuvant therapy, is there any downside to operating on them later if their tumors recur? And we know about a third, 33% of the tumors will have what we call regrowth, which is not necessarily a recurrence, but it means that the tumor has come back with evidence within most of the time 1 to 2 years, although it can happen at any point after undergoing this therapy. And is there any downside to doing surgery at a later point, and will that impair survival? So this study was out of Brazil, which is actually one of the hubs of where the watch and wait protocols originated about a decade ago. So this looks at patients over an average of almost 5 years with quality of life, and also those who had recurrences and then underwent resection afterwards. The only patients included were those who had complete clinical response, which obviously if you have evidence of disease after doing your treatment, you should not be observed. Now, it is interesting in this study, they did not give them full chemotherapy with FOLFOX as the other studies had. They just got radiation with oral capecitabine. And then they did have surveillance starting around 8 to 12 weeks after surgery, which is the standard of care. And then those who had near complete response were then further evaluated a few weeks later to make sure that everything was indeed clinically gone. So 67 patients qualified for this study. The remainder of over 700 that were in this evaluation did either have evidence of disease or they underwent surgery without being in a watch and wait program. Of these, about a third, once again, did have evidence of local regrowth at some point in their surveillance interval. The majority of these, though, were within about the first year. The remainder of the group did not have any evidence of recurrent disease, and so that's where these were compared. So this is just a breakdown. I'm going to fast forward through showing the difference between the two groups. But more importantly, those who did have a recurrence, almost all of them underwent surgery. Of those, 75% had surgery where we removed a portion of the rectum, but they still ultimately down the road were able to have continence and live life without an ostomy. 25% had an abdominal perineal resection, which means that the anus, rectum are both removed and that they are left with a permanent colostomy bag. Of those who underwent the surgical salvage procedure, 3 of them did have a recurrence after the salvage. Interestingly, in this, 2 of the 3 did have positive margins at the time of surgery, which I think would definitely put them at the category of having very high risk for this to recur anyway. So that's not a complete surprise. What is also important is of the group of 20 patients who had a recurrence, there was still a 71% long-term 5-year survival. And this correlates with an average patient who has undergone surgery with rectal cancer. So it doesn't seem to be a diminished survival effect of those patients who were having delayed surgeries after regrowth. Now, this, as I mentioned, correlates with a lot of the meta-analyses that have been done, and it's pretty standard idea that most patients do get to surgery if they have regrowth, and those who do undergo surgery have almost the same long-term life expectation as those who don't. The main reasons that patients did not undergo surgery in this other group were those who refused it, or they had comorbidities which precluded them from being surgical candidates, or they developed metastatic disease that was unresectable from a primary standpoint. Now, one of the other caveats is I mentioned they did not have chemotherapy in the initial phase of their treatment, and that could obviously have a big impact. And I think a lot of more recent studies have shown that total neoadjuvant chemotherapy and radiation seems to be a lot more effective. Now, granted, 10 years ago, that wasn't the standard of care when we were looking at these long-term data, and so I think that will be interesting to follow as time progresses. The last topic I wanted to bring up was when we do go to surgery, one of the old dogmas was in rectal surgery, even with the advent of minimally invasive techniques, that open surgery was preferred. There were multiple studies about 15 years ago that showed that open surgery had better outcomes than laparoscopic or minimally invasive surgery for rectal cancer. And so I wanted to pull up, this study is one of the longest following patients who have undergone both open and laparoscopic surgery over a 5-year period to see what the recurrence was and see about distant metastatic disease and as well as 5-year survival. And this was done in Japan, which involved 69 institutions, so it was quite a large scale study. And they performed these procedures at the same, the same time interval. It wasn't like they compared open surgery from 10 years prior to laparoscopic surgery currently. Now, these were done around 2010 to 2011, but at that time, there was still pretty good advancement in laparoscopic surgery, and most of the surgeons were well equipped to handle it. Now, one of the interesting things is that the approach of the surgery was chosen by the surgeon. It was not randomized. And so, some surgeons that do open surgery, had been doing it for 30 years, may have been a lot more comfortable and not as proficient laparoscopically. And so it would be interesting to know from a surgeon who was equally capable how the outcomes would be. Out of 1,500 patients, 964 were used to match into 2 groups, both the open and the laparoscopic group, and they were propensity matched for multiple factors that you can see here. They were followed on average for 5.5 years, which is the longest of any of the studies that we have comparing these 2 things. All of these patients also were a stage 2 or 3 rectal cancer, which means they have not had any evidence of distant metastatic disease at the time of their surgery. And they were all below the peritoneal reflection, which means in the lower half of the rectum, which is the more true rectal cancer that we consider. So this just kind of breaks down the propensity matching, if anybody wants to look at that later. But the more important information is the survival data. So at 5 years, the recurrence-free survival was statistically not significant between the 2 groups, which is very important. They're both in the mid 60% range. And then the overall survival is also not statistically significant, meaning there's no inferiority to doing a minimally invasive surgery. With this information, it's important because patients typically recover more quickly, they have less pain, they have faster progression to chemotherapy and other adjunctive therapies following their surgery because they have healed more quickly. And so there are a lot of benefits to doing minimally invasive surgery, and we were just trying to make sure that there weren't any downsides to doing so. It did further break these patients down into those who did have a recurrence. As you can see, 134 in the open group and 149 in the laparoscopic group. And the vast majority of these were local recurrences. And it kind of breaks down those who had more distant recurrences where they were. The majority are the lung and the liver, which is the standard place we would expect them in rectal cancer. And then a few people did have recurrences both locally and distantly. So in those patients who underwent salvage surgery for their recurrence, you can see that only about a third to 40% of these patients actually underwent surgery. And we don't know what the factors were that limited the remainder of the patients, whether it was distant metastatic disease or they weren't surgical candidates from comorbidity standpoints, or they didn't want to proceed with additional surgery. But of these who did go to surgery, this shows that they do have benefit from having resection of their recurrent or metastatic disease. So in both the open and the laparoscopic groups, when we put them all together, there's clearly, as you can see in the two graphs, significant benefit from removing metastatic disease if it is amenable to that. So one of the factors that we mentioned or was mentioned in the paper is that we don't know what the TME status. And what that means is when we remove the rectum, we have to make sure we get into the correct plane that we remove all the lymph nodes that surround the rectum. And that's one of the grading criteria that we as surgeons grade ourselves on in quality of surgery that we do. And so that has become a standard of care. And so we don't have confirmation that all the patients who did not have recurrences, specifically local recurrences, didn't have any issues with the TME during their surgery. And also minimally invasive surgeries, including robotic and laparoscopic surgeries, are now more common and probably the standard of care. And the learning curve has been increased greatly for surgeons who perform these minimally invasively. And so I think that if we, look at the data now in 5 more years, I think there will also be even, more similarities between the two groups with almost no difference. And the last thing is there was no randomization. Again, it was surgeon preference as far as laparoscopic versus open. So it'd be interesting to see a randomized trial. So I have a couple of questions that we put on here just kind of regarding what we've talked about. So one of the big things that we talk about with the watching and waiting are who are candidates and who are not candidates. And so is this something that I go over? I'm sorry. Okay. Oh, awesome. Okay. All right, good. Yeah. So it just kind of goes to show, I mean, it's not ridiculous, but patients who have a very low hemoglobin would be somebody who would, be somebody we need to consider operating on. But the remainder of people have no evidence of disease. And so therefore we can consider waiting and trying to preserve the rectum. There's one additional question here, and I will note on option C, it says regrowth thinks it's supposed to say regrowth. I apologize for that. Yeah, exactly right. So people who are total responders, we consider not doing surgery for. So, all right. Thanks, everybody.
Thank you, Dr. Jones. You have won the award for the best scores of your questions. You have taught the audience well. 2 for 2, 100%. Probably was AOA. Am I right? Anyways, okay. So continuing our excellent talks with GI oncology, Dr. Nelson is our medical oncologist who will be speaking to us about these cases. And I think I messed up. I started from the wrong slide. So please excuse me. I'll get you to where you need to be. Maybe. Okay, here we go. Perfect. Well, welcome, Dr. Nelson. Thank you. Thank you. And then there should be where's Dr. Jones? Here it is. Sorry. Here you go.
Well, thanks very much. I know it's Friday afternoon, so I applaud all the folks that stuck around. Let's talk a little bit about medical oncology and GI oncology. So I'm going to talk to you about a few themes today. Certainly, we cannot cover everything. GI oncology goes from the esophagus to the anus and everything in between. So we'll talk about a few themes, especially focusing on lower GI oncology. And so those themes are a few that I think are really emerging. One is the idea of systemic therapy, meaning drugs, being increasingly given in the neoadjuvant setting before surgery. When I started my medical oncology training, most cancers, if they were able to be resected, the treatment was surgery, and then we would consider other treatment options like chemotherapy or radiation therapy. But what we have found over time is that there's a lot of value to considering giving some or even all of the other treatment and then doing surgery if it's even necessary. Another theme that has really come to the fore over the last 10 years, and it's amazing how many different cancers are all benefiting from the same strategy, is the idea of harnessing the power of the immune system to fight cancer. And we've had perhaps not as much success as some of the other cancer sites, but we are having a lot of success in selected patients with immunotherapy, and that is continuing to expand, and we are continuing to use that in an earlier state of disease. We're also getting much more sophisticated over time at finding small amounts of cancer, which allows us to better choose which patients truly need treatment, which patients may not need treatment. And the general term for this idea of finding very minute amounts of cancer is minimal residual disease. And so we are getting better at finding minimal residual disease. And then the last is a general theme in all of oncology is the increasing use of targeted therapy. We don't treat all cancers, all lung cancers or all colon cancers or all breast cancers. We don't treat them the same way, the way we did 15, 20 years ago. We divide them up based on molecular findings, especially, and changes in the DNA, and we try to tailor our treatments to those specific abnormalities. So specifically, when we talk about rectal cancer, Dr. Jones already talked quite a bit about this idea of TNT, or total neoadjuvant therapy. And that's something that is really becoming very popular and has expanded greatly in use over the last several years. So this idea of giving treatment prior to surgery, there are a lot of both practical and some more theoretical advantages, but we know that if you can shrink tumors, that you may make things easier for your surgical colleagues. You may allow them to do less of a surgery. There is a greater chance that when you get that pathology report back, that pathology report will indicate negative margins, you got it all. And in some cases, and this is one of the goals of TNT in rectal cancer, you may even eliminate the need for surgery entirely. We know to chemotherapy, patients tolerate getting chemotherapy a lot of times much better if you give that chemotherapy prior to surgery. In the case of rectal cancer specifically, there are plenty of studies that have shown that in times where we gave most of our chemotherapy in the adjuvant or postoperative setting, that up to 40% of patients who should be getting chemotherapy never get it. And there are a variety of reasons for that. But we know that a lot of patients just simply don't get treatment if you wait until after surgery to try and give it. This idea of giving treatment prior to surgery, this is pervading quite a bit of GI medical oncology when it comes to gastric cancer, esophageal cancer, pancreatic cancer, and rectal cancer. We have all shifted the use of chemotherapy forward into the setting prior to surgery, because we know that it's much more likely to provide benefit and patients are much more likely to actually get the treatment. It's also a test of tumor biology. This is true perhaps most often seen, I think, in pancreatic cancer, where we often, when we talk about pancreatic cancer, we're talking about a large surgery. So the so-called Whipple surgery that you've heard about, that's a big surgery. And there's nothing more frustrating than doing a Whipple surgery, having a patient have a prolonged, long recovery, doing the first scan after that surgery and finding a bunch of new metastases. And then you feel like you've essentially done that surgery for no real benefit. And so giving patients chemotherapy prior to surgery, it allows you a period of time to make sure that they are not going to sprout, so to speak, a large number of metastases, and you're selecting patients for surgery who are truly most likely to benefit from that surgery. So the OPRA trial, there are a number of trials looking at this total neoadjuvant approach in rectal cancer. The OPRA trial is one that has received a lot of attention recently. And this was a trial where they looked at patients who had a distal rectal cancer, which is a real target group, because surgery for these patients often means that they will have to have a permanent colostomy. So, this is, even if they are cured of their cancer, this is life altering for them. And so this is a group where we would really like to avoid surgery if there was any way to do it while still curing them of cancer. So this trial basically was a trial looking at whether it's best to give chemo and radiation first and then chemo versus give chemo and then chemoradiation. And in this case, if they were restaged after that total neoadjuvant approach with both chemotherapy and radiation prior to surgery, and if they had a clinical complete response, as Dr. Jones was talking about, then they could be eligible for a non-operative approach or a watch and wait approach. And so what they were able to prove in this trial is that with that approach, 50 to 60% of patients could end up being TME free, or total mesorectal excision free, meaning they could actually avoid surgery and hopefully be cured of their cancer, although they need to be watched closely. So 50 to 60% of patients could preserve their rectum, and this is with 3-year follow-up. So next theme is this increasing use of immunotherapy and using it earlier. So this is a trial I'm pointing out. This actually is not a rectal cancer trial. This is a gastric cancer trial, but it illustrates the theme. And so this is a trial that looked at patients that had gastric or GE junction adenocarcinoma, and they had a specific pathologic feature, which is that these patients were either they were MMR deficient, so mismatch repair protein deficient, or MSI high. This is most often associated with Lynch syndrome, but you can see it in other settings as well. And these patients received just 12 weeks of immunotherapy, so 2 drugs, nivolumab and ipilimumab, and then surgery. So with 12 weeks of treatment, and we know that this finding of either MMR deficiency or MSI high, that is a marker for folks attention and really promise a lot for the future. So the next theme is this idea of the more sophisticated. Confident, they are almost always going to relapse after surgery. On the other hand, if their circulating tumor DNA is negative, they have an excellent prognosis. And, in these trials, on the right there, stage 3 patients for which the normal standard treatment after surgery is chemotherapy. So stage 3 chemotherapy is standard, but yet they have such a good prognosis. If their circulating tumor DNA is negative, maybe we don't need to give them chemotherapy. And so that's where we're headed as a community, is to try and use this information to make better decisions. This was a recent trial looking at stage 2 cancer patients. Stage 2 has always been a controversial area. I mentioned already that stage 3 chemo is standard. Stage 2, it's all over the place. Some patients get chemo after surgery, some don't. Some get less aggressive chemo, some get more aggressive chemo. And there are various guidelines to try and make these decisions, but it's a more difficult decision. What this trial did is it looked at the use of circulating tumor DNA, and patients either got standard management, where the oncologist looked at all the normal things we look at, the patient, their comorbidities, their age, their pathology report, and tried to make their best judgment about whether to give this patient chemo and what type. On the other hand, the other group used the circulating tumor DNA result to make a decision about whether they should get chemotherapy or not. If they were ctDNA positive, they got chemotherapy. If they were negative, they didn't. And so what this trial ended up showing is that if you used the ctDNA guided approach, that you could give a lot less chemotherapy on the one hand. So a lot fewer patients required chemotherapy. The patients that did get chemotherapy tended to get more aggressive chemotherapy because their physicians were aware that having ctDNA positive is a bad thing. And it's been shown to be a very highly negative prognostic feature. But that you could actually have excellent outcomes with this ctDNA guided approach. So if you were ctDNA negative, your chance of recurrence, even though most of these patients didn't get chemo, chance of recurrence was very low, well under 10%. And on the other hand, if the ctDNA was positive and patients got chemo, they still looked like they had a fairly good outcome. So this seems to really be a powerful tool in this trial to help us choose how to treat patients with stage 2 cancer. I'm going to highlight this study that we actually have just opened at Norton. And so this is a trial that we're currently looking for eligible patients. So again, this is a stage 3 colon cancer patient trial. Again, stage 3, the standard treatment for these folks after surgery is chemo. But what this trial is doing is this is now looking at the use of circulating tumor DNA to stratify patients and help us design treatments that are more sophisticated than just saying stage 3 equals chemo. So if these patients have no ctDNA recommended, then they get randomized to chemo, which would be considered standard care, or they get randomized to observation, which would certainly not be standard, but on trial, and we have very good reasons to think that that might be an appropriate strategy. On the other hand, if their ctDNA is positive, and we know these patients have an incredibly high risk of recurrence, then they get randomized to either standard chemo again, or they get randomized to an escalated chemotherapy, including an additional drug that we don't normally use in the adjuvant setting. So these patients, maybe their risk is so high that they need even more aggressive chemotherapy than what we would normally do. And so, these are the kinds of studies, and there are other ones as well, but that hopefully can make us better and better at making decisions about which patients need treatment and then how aggressive does that treatment need to be. Last theme is the idea of targeted therapy. And you've heard this, I'm sure. I didn't see all the earlier presentations, but I'm sure you've heard this multiple times so far today, which is that we used to treat all lung cancer the same, and we used to treat all colon cancer the same, and we used to treat all breast cancer the same. And we just don't do that anymore. Now everything is at the molecular level. It's not one pie, it's a whole bunch of small slices. And some of those slices are only 2% of the patients or 3% of the patients. But we know that if you give those patients a specific targeted therapy, they have a much better outcome than just the quote standard treatment. So this trial uses a drug called trastuzumab deruxtecan. This is for HER2 positive gastric cancer. And you can just see the waterfall plot there. So, again, the picture speaks for itself. You can see what excellent responses to HER2 targeted therapy you can get if you have a HER2 positive. This was gastric cancer, but we see similar results with HER2 positive colorectal cancer. And this is a relatively small percentage of the patients, but it makes a big difference for these patients. This is a colorectal trial called Mountaineer. And again, the same idea. With a HER2 targeted approach, you can show some very, very good responses. And these approaches are, as with most therapies, starting off in the more advanced disease setting, and now they are moving forward into earlier stages of disease. And that's all I have. Thank you.
Thank you, Dr. Nelson. That was amazing. It's so exciting to see the research that's being opened at Norton Healthcare and all the state of the art. I mean, we have a blood test now to say, how does this complement your physical exam and your imaging studies? We've got targeted therapies. We heard in the breast cancer section about the trastuzumab isomerase conjugate. Now we're using that in other HER2 positive cases. And the ultimate targeted therapy is radiation therapy. And so Dr. Altus will come up here and explain this role. And then once he's done with his session, we will do a case or two with the whole team. So thank you, Dr. Altus.
So my name is Dr. Bassel Altus. I'm a radiation oncologist at Norton Cancer Institute. And I'll try to be as quick as I can to respect everyone's time in this Friday afternoon here. So today I'm going to try to focus the talk on rectal cancer and radiation therapy. Fortunately, I have nothing to disclose. And so I was going to talk a little bit about what is radiation therapy. I know we spoke quite a bit today about radiation therapy, and I know there's a lot of non-oncologists in the audience, but I will skip that just for the sake of time and just focus on radiation therapy and rectal cancer. I'm going to talk about the benefits of radiation therapy, whether we should be doing it before or after surgery, its role in total neoadjuvant therapy, the short course versus longer course radiation therapy, and then the role of radiation therapy in the setting of trying to avoid surgery. And we did talk quite extensively about that. So I'll try to just highlight a little some aspects regarding radiation therapy there, and then whether or not we can avoid radiation therapy. So I'll skip through this for the sake of time. So radiation therapy, historically, we used to actually benefit overall survival, cancer-specific survival, and local recurrence rates. Basically, when we did radiation therapy, patients lived longer. Now, in the era of the total mesorectal excisions, we improve local control, but no longer improve overall survival and cancer-specific survival. But for those who treat rectal cancer, they are fully aware that local recurrences are very morbid. And so the significance of local control is very important. So now that we know that radiation benefits patients locally, should we be doing it before or after radiation or after surgery, excuse me? And so the neoadjuvant therapy, the reasons why it's smart or reasonable to do is allows for less normal structures to be irradiated. When you have the tumor intact, you have a tumor that you can treat instead of a post-op bed where a lot of the normal organs are replacing that area, leading to more of the normal tissue being radiated. Increases R0 resections. The potential downside is that it results in overtreatment of patients potentially if you're doing neoadjuvant and they don't actually need it after pathologic evaluation. But this is a much less of a concern with MRI staging. Now that the MRI is very accurate, patients are typically staged accurately, and so it's less of a concern from that perspective. There is a German trial, as one of our seminal trials, that demonstrated neoadjuvant actually had less toxicity and improved local control compared to adjuvant radiation therapy. And so that's another reason why we are doing typically neoadjuvant radiation therapy. That study showed that there was a good local control benefit, that we got about 10% pathologic complete response. But one of the concerns and current problems was that there was high rates of distant metastasis, meaning the cancer is spreading elsewhere, around 30%, which led us to one of the reasons why we decided on trying to bring the chemo more up front so that hopefully we can get rid of those cancers that may have spread elsewhere. The two trials that also kind of propelled this approach, and they're kind of more recent trials, are the Rapido trial and the Protege trial. They demonstrated that with bringing the strong chemo, the FOLFOX and CAPOX, with the chemotherapy neoadjuvantly, improved disease-free survival in our patients compared to doing the chemotherapy afterwards. As Dr. Nelson mentioned, we're able to actually treat more people with a stronger chemo when we're doing it neoadjuvantly. About 50% of patients in this trial were not able to complete their adjuvant chemotherapy. We also demonstrated that with the neoadjuvant chemo, we were able to increase the pathologic complete response, therefore allowing more patients to pursue this watchful waiting approach. So one of the things that the Rapido trial did that kind of propelled this certain type of radiation therapy called short course radiation therapy, which could be done in 1 week instead of 5.5 weeks, was the Rapido trial. It's become more common in the US since then. It's very common treatment modality in Europe. The reason why it's well liked is that it's more convenient, less costly, but there is some concern that the local recurrences or the cancer coming back might be higher with the use of short course radiation therapy. Although the trials that I've looked at this showed that it wasn't statistically significant, just numerically higher. And the idea is that there is less biological radiation dose with the short course radiation therapy. For me personally, I like to favor the, if we're going to try to aim for surgery for our patients, I don't mind doing the short course or the long course chemo RT. But in patients who are approaching or want the watchful waiting approach, which is trying to nix the surgery, I do prefer the long chemo radiation because of the higher biologic dose, as well as most studies, including the OPERA study that Dr. Nelson discussed, used the longer chemo radiation approach. This is a recent study that evaluated watchful waiting. It kind of compared chemotherapy and chemo RT and the different sequence of each, but not to kind of dive too much into detail and just kind of highlight the radiation here. One of the things that it demonstrated was that using chemo radiation up front and then chemotherapy followed by surgery led to higher percentage of patients not requiring the surgery, the total mesorectal excision. It also defined a good watchful waiting strategy. It allowed us to give us a good protocol of how to follow our patients. And it also demonstrated that in patients who did undergo watchful waiting and had a recurrence afterwards, their overall outcomes were not compromised compared to patients who went to upfront surgery, which is also good because there was some concern with watchful waiting that we might be burning a bridge. So we talked about patients who do achieve a complete response. Can we not do the big surgery with patients who don't achieve a complete response, but can undergo a transanal excision? There is a study called the Grecar study that evaluated chemoradiation followed by transanal excision in patients who had T2 or T3 rectal adenocarcinomas, but did have a good response to therapy. And that compared to the standard chemoradiation and then the bigger surgery. They found that there was no difference in local recurrence, distant metastasis, overall survival, but it was not a non-inferiority trial. So statistically speaking, it was considered a negative trial. So the standard still remains the chemoradiation followed by total mesorectal excision, even in patients who could undergo a transanal excision for those who respond well. But I think this is a decent approach, a reasonable approach for very select patients who are adamantly against surgery or the bigger surgery, or those who just can't tolerate bigger surgery. And there are other phase 2 trials that demonstrate good outcomes in that approach as well. Now the question is, do we even need radiation? And for the most part, yes, as I mentioned earlier, it does improve local control, but there are a select population who would otherwise require radiation therapy that we might be able to omit. NCCN has a set T3 population who they recommend potentially avoiding RT. And then there is a UK Mercury trial that defined this low risk group, which are high rectal cancer group, high rectal cancers, T1, T3B, with very little extension outside the rectum. They were not near the mesorectal fascia and then didn't have other concerning pathologic features. There is an ongoing trial called Prospect that's evaluating a broader group of patients and seeing if we can omit radiation therapy in them as well. Those patients undergo chemotherapy, and if they respond well, then they undergo surgery without radiation therapy. And we're trying to see if we can potentially eliminate radiation therapy there as well. So just to summarize, radiation therapy in rectal cancer does improve, does have a benefit, improves local control. Typically, you want to do it neoadjuvantly because the toxicity is better, including the local control. It has its place in total neoadjuvant therapy, and I prefer a long course chemoradiation watchful waiting, but short course or long course is good otherwise in other settings. And then we can avoid surgery, although we talked a lot about watchful waiting, but it's still not considered standard of care. But I think if you have, a solid group of colleagues, and here in Norton we do, where patients are followed very closely, and we have good support staff to make sure patients don't fall through the crack, I think is a very reasonable approach. And then can we avoid radiation therapy? And there are select patients we can, and potentially more patients in the future. So thank you so much.
You can stay. So we're going to go ahead and bring the whole team up here. They've got a fantastic case that we're going to go over. So I would invite all the members of the multidisciplinary team for lower GI to come up to the stage. And then I think we have your case slides loaded here. The only request I would make of the team is that if you haven't spoken yet, we need to introduce yourself to the audience so they know who you are and your role. And then also, I would ask who would want the sacred clicker to advance the slides. I'll take it. Dr. Nowacki, thank you. So I believe if you go to the next slide, it will start our case.
I'm going backward.
I think it's the green button.
Okay, got it.
Thank you, sir.
All right. So case one is a 42-year-old guy who went to his primary care physician complaining of intermittent rectal bleeding and some constipation and occasional rectal pain. He was sent over to GI and had a colonoscopy performed, and you can see the pictures here that he has a large mass in the rectum that's partially obstructing. And you can go to the next slide. Biopsies did show invasive adenocarcinoma or rectal cancer. So there was a polling question. Okay. I don't know if you want to. All right. So after diagnosis of cancer, what kind of imaging would need to be obtained?
Don't let Dr. Jones down. His 100% is on the line.
All right. So there's not 100% here, but that's okay. So typically what we would do is we start off with the CT of the chest, abdomen, and pelvis just to look for any evidence of metastatic disease distant to the rectum itself. And in rectal cancer, we do perform MRIs as they're more appropriate and they show a better evaluation of the tumor itself and any enlarged lymph nodes around the rectum. So we would technically do the CT chest, abdomen, and pelvis with an MRI of the rectum. So he was then sent for radiation therapy with oral Xeloda. You can kind of see the radiation fields that are marked here. Basil, do you have anything to add to?
No, nothing to add. Historically, we used to do a 3D conformal radiation therapy. This is a 3D conformal plan. I typically like to do intensity modulated radiation therapy, but there are some studies that should potentially show that it's not probably better in rectal cancer. It's definitely not worse. But when you review the plans itself, you can kind of definitely tell there's less radiation to normal structures. And so if I can get insurance to approve it, that's what I attempt to do.
And I will say in this situation, we did discuss, I came onto his case a little bit later. He was previously at a different facility, but he underwent radiation first instead of doing chemotherapy first, or in what order, as we had alluded to in some of the trials, due to him having the bleeding and the obstructive symptoms, to try to alleviate the bleeding and allow him to poop without having to have an ostomy or some kind of interventional surgery first.
And just, I guess, real quick, Dr. Dewacki, was there anything relevant on pathology from the biopsy that would be worse?
Not really. It looks like a standard moderately differentiated cancer. Yeah. So I just wanted to say, right, just the Norton Healthcare, our lab was the first, I think the first institution in Kentucky to start doing those MSI on every colon cancer. So that was a real move forward for us, I think. Anyway.
All right, so this is just some imaging where he was restaged after undergoing radiation. He's had improvement in his tumor, but there's still some concern for enlarged lymph nodes as well as some residual tumor.
Can we go back to the previous slide? Dr. Kelly, I didn't know if you had any comments on the MRI of the pelvis, or how this helps us or doesn't help us, or your thoughts.
I think for here, it's hard to see from my angle, but I believe there was a small lymph node there. So it keeps us, I guess it helps us know where we're at, in our treatment plan, but I can't.
Yeah, it's really, really hard.
I guess, and I think honestly, the question before about what imaging to select was tricky too, but all those studies do eventually get ordered, but I don't think many people have to stress about what to order. CT, chest, abdomen, pelvis, get you going, and the higher end stuff, you can let these guys kind of figure out the order for.
And so this patient then got treatment with Folfox, which is one of our standard chemotherapy regimens. We've been using 5-FU as one of our standard chemo drugs for colon cancer since the 80s. Oxaliplatin came on the scene a little bit later, early 2000s. But the Folfox regimen is one of our standard backbone regimens for colorectal cancer. And as 8 cycles is a pretty typical number, so 16 weeks of treatment. So keep in mind, when we talk about giving these patients total neoadjuvant therapy, they're getting about 6 months of treatment before we're even thinking about whether we need to do surgery or not in most cases.
So this is just a view of the sigmoidoscopy after he completed the chemotherapy. And you can see, compared to his initial pictures, there's no evidence of tumor left, and biopsies are all negative. An ulcer, that little white spot in the middle picture, is considered a standard okay thing for evidence of tumor regression after radiation therapy. So then he was just put into a watch and wait surveillance plan. All right, so he was in the plan, and then after a year, he did have a CT as part of his surveillance, which did show concern for a mass recurring and possible perirectal lymph node. You can see the positive arrow sign down there. And then, so we took him for a flexible sigmoidoscopy, and you can see the significant difference from the last slide, which showed no evidence of a tumor to now tumor. And then that was biopsied, showing an adenocarcinoma once again. Okay, well, so the answer to that question was it technically does not show any difference in survival long term. So he then underwent surgery, and given that his tumor was very low, almost above the anal sphincters, he did have abdominal perineal resection, which is removal of the rectum, the anus, and part of the sigmoid colon. You can see the specimen there. And he did have a complete total mesorectal, or TME, excision, which encompasses all those lymph nodes. And then of his pathology, Dr. Locke, do you want to talk about with one tumor deposit but no nodes?
Yeah, so if you find, okay, after chemotherapy, you look for lymph nodes. You're supposed to find at least 12 lymph nodes. So we try to find 12 lymph nodes. And then in addition to that, you sample the serosa around the colon, and you look for what these things are called, tumor deposits, or extra or tumor nodules. Anyway, so if all the nodes are negative, and there's one tumor nodule, tumor deposit, then that gets a nodal stage of N1C. But the thing is, after chemotherapy, you have to make sure that a lot of times there's tumor that's like skip tumors after chemotherapy. If you were to find tumor, so if you find a nodule in the wall of the colon and a nodule somewhere near the external part of the muscularis propria and another nodule in the serosa, it could be that the one in the serosa is not really tumor deposit, but might just be tumor that did fail to respond to the chemotherapy. And initially it was one whole tumor. So you have to, after therapy, if you find residual tumor, you have to sort of try to figure out if that extra colonic nodule is in fact a tumor deposit, or it's just residual tumor that wasn't affected as strongly by the chemotherapy. So that's sometimes problematic in pathology, I think.
I will say with APR, we usually have to do a big wound management of the bottom. This gentleman had a flap, so his rectus abdominis muscle, including the skin overlying this, we have plastic surgery there who did a flap down to the pelvis to kind of fill this defect. Knowing that would be difficult to heal, and these often are, we did give him what we would normally do as an adjuvant chemotherapy, given the enlarged lymph nodes before surgery, so that way it would be delayed in getting to him if he did have node positive disease. So I did forget to mention that. That's why he underwent the chemotherapy prior to surgery.
And just real quick, Jacqueline, I invite you to comment, given your expertise in perioperative nutrition in advanced oncology patients with flaps and complex wound closures. Is there anything from a metabolic point of view that you interface with these patients to help them with, or goals of nutrition?
Yeah, sure. With patients undergoing a big GI surgery, maybe not so much this one because it seemed like he had to go right to surgery once his recurrence was identified, but it's really important, especially for the upper GI oncology patients, to have really thorough nutrition support before that operation. It plays a big role in whether or not they remain a surgical candidate, and it actually can influence outcome and recovery from the surgery that can dictate and really influence their timing of return to treatment. So in a patient like this, if he needed additional treatment, we would try to follow him closely so that he could start that treatment in a timely fashion.
And he's now about a year out, and he has been surveilled with the Signatera, the circulating tumor DNA that Dr. Nelson was talking about in his slide, and he has remained negative since then. So hopefully that is a good omen for him going forward.
So it's a good example of a patient where, we tried for a non-operative approach. We gave him total neoadjuvant therapy, and unfortunately, we know that doesn't always work. But with watching him closely, when he did have a recurrence, we feel like we hopefully have now salvaged him, and he did have to have surgery, but hopefully he's still going to be cured of his cancer.
Hey, can I ask a question? So when you're doing this circulating tumor DNA, is there a specific time to do it, or do you do it multiple times, or how many times? What's if it's negative one time, you do it 6 weeks later. If it's positive, how do you figure that out?
Yeah, I mean, that's a great question. And I think circulating tumor DNA is a relatively new technology. It's been around for a few years, but it's only been used outside of research trials, very recently. And there's still a lot we don't know. So we don't know, is doing it once enough? Should you do it every few months? How long should you do it? We know in the case of rectal cancer, the vast majority of recurrences, especially the local recurrences, are in the first 2 years. So maybe that's the most intensive time where you should be monitoring. Many of you are probably familiar with the CEA blood test, the carcinoembryonic antigen blood test, which that's been the way that we've looked for recurrences, outside of imaging. That's the way we've monitored patients in the past, and we still do. And we often check that every 3 months. And so for lack of a better guidance, we are often doing the ctDNA every 3 months, but it's basically copying what we have always done with CEA. And we still are finding out, what's the actual optimal schedule for that.
Okay, I guess we'll go on to case 2. So this is a 57-year-old lady who presented to her primary care with intermittent blood and stools. She'd never had a colonoscopy before, and so was referred to a surgeon for this, and ultimately had a palpable rectal mass on exam. She underwent a colonoscopy, which did confirm this rectal mass as invasive adenocarcinoma, starting in the mid-rectum from 6 to 11 centimeters away from the anal verge, which is kind of how we measure rectal tumors. We did an endoscopic ultrasound and got an MRI, and that confirmed that she had a T3 and N1 disease, which means that she did have positive nodes and she qualified for total neoadjuvant chemotherapy.
I'll point out if we can go back real quick, Mike. I think it's good to point out that, this patient was MMR proficient and microsatellite stable, which, would again suggest that immunotherapy wouldn't be a future option for this patient. And that's the majority of patients. But the important point to point out is that this is checked, and this is checked on every colon and rectal cancer. And as, Dr. Nowacki was saying, it didn't used to be this way. And that's something that has changed over time. I wasn't aware that, Norton was a real leader, in the state of Kentucky in helping to push that change, a number of years back now, that they started doing that. And that's now, a standard thing that we do for every single patient.
This just shows the enlarged lymph node in her rectum on the picture on the left. And then she had a small lung nodule, which is about 3 millimeters in size, which was too small to further characterize at her diagnosis, but was something to be watched going forward.
And Dr. Kelly, do you have anything to add with those studies?
I think what's important is that each of these studies are complementary. We're each specific study, the CT on the right, the MR on the left, and then PET, they all work together. They all give different types of information. So you're often going to see on these patients having multiple different types of imaging studies at certain specific times in their treatment. And they're well thought, they're discussed at each of our conferences now twice a week. And we're trying to pick the best test at each time for each individual patient.
So this just shows that she underwent her total neoadjuvant therapy, again with FOLFOX as the last patient had, as well as chemoradiation with oral 5-fluorouracil.
And of course, this patient had a different order of treatments given compared to the first case.
Correct.
This patient started with chemo, then did chemoradiation. The prior patient, that was the vice versa. And we're still trying to determine what's the best order to do these things in. We feel like doing all of that treatment prior to considering surgery is the right thing to do, but we're still fine tuning what's the best way to do that.
So from my perspective, she's had a complete clinical response from an endoscopic evaluation and for her rectal MRIs. But I'll let maybe Basil talk a little bit about whenever we surveil for lung and then treatment of anything concerning in the lung.
So how frequently we
Oh,
surveil?
sorry,
the
that's the
lung?
next slide. I'm
Sorry.
sorry. Apologize. This is
So-
where her lung nodule has increased to 9 millimeters from 3.
Yeah, so I mean, typically when we're worried about potential lung cancer, typical surveillance, depending on the lesion, the size of the lesion, would be every 3 months. I'm not sure how frequent this patient received our CT chest, but it sounds like as soon as we saw that the lesion was growing in size, we referred it to our great interventional radiologist to biopsy the lesion and
It was metastatic disease.
And just for perspective, 9 millimeter lesion is smaller than most people's pinky nail. So with the technology Dr. Kelly and his teammates have, they can non-invasively get tissue sampling. That's always a huge chunk of tissue, right, Dr. Nowacki? Way more than you need.
That would be false.
Except for me.
The interventional radiology folks, I mean, they're often the heroes because, you've got this tiny little nodule, it's deep in the lung, and look at what they did, I mean, they went through all that tissue with that long needle. You see the picture on the right, and you can see that's the picture with the needle going into that little nodule, and they get a diagnosis for us. And these days we're really, really pushing them because we do want to get all these molecular studies. And so, we actually are pushing them to give us bigger and bigger chunks of tissue rather than just a few cells. So they do a great job.
Not really pushing hard enough, I think.
The other thing we see now too is at different points in treatment. It's not just useful to have the sample at the initial diagnosis, but getting if the tumors evolve, if you develop later metastatic disease and treatment, we're repeating biopsies to get current molecular profiles to guide treatment further down the road.
Maybe, can we go back one slide? So just a quick comment, this comes up a lot. If we're following patients and we see something new. So in the case of this, we see a lung nodule. The question always comes up, gosh, is this going to be a recurrence of their prior cancer? Or, hey, maybe it's a new lung cancer. Maybe it's totally unrelated to their prior cancer. And so that's where we ask our pathologists to really help us. And, Mike, maybe you can tell us what that IHC profile
Sure.
means.
So when we have an adenocarcinoma, then there's a differential diagnosis of primary versus metastatic. And so what we usually do is a series of immunohistochemical stains. And usually if it's in the lung, we start out with the TTF1, which Dr. Wunderlich talked about, which is a thyroid transcription factor 1, which is also positive in adenocarcinoma in the lungs. We start with that one. Then we also have another adenocarcinoma in the lung, napsin A. We use that one. And then we have 2 keratins that we use. So CK7, cytokeratin 7 is positive in lung cancer, breast cancer, thyroid cancer, but negative in colon cancer. Then CK20 is positive in colon cancer and negative everywhere else. So, and then we have this new stain. And then we have another 2 stains that are specific for colon cancer. One is called CDX2, which is positive in colon cancer. And the newest one is the SATB2, which is positive on the colon cancer also. So if the tumor is positive for SATB2 and it said CD20, but it's actually CK20 and CDX2, then that would support a colonic colon carcinoma. And if it's negative, and if it's positive for cytokeratin 7, TTF1, and napsin A, then that would support a primary pulmonary adenocarcinoma. So we can tell the organ a lot of times by the immunostains, but there are a few organs where the immunostains are not specific. For instance, the pancreas and the bile ducts and the small bowel, they all have various stains. So we don't have anything specific for those organs. So we have to say something like tumor positive for CK7, given the clinical history, it could be from the upper GI tract or pancreatobiliary tract. Then we have to say that. Also, the stomach's included there. So those organs we can't really pinpoint, but usually the colon we can pinpoint, the lung we can pinpoint.
And so this particular result pretty much guaranteed us that this was a recurrence of this patient's colorectal cancer.
So this patient underwent stereotactic body radiation therapy. And so in the rectal cancer, patients who have like a few sites of disease that spread outside the rectum or oligometastatic disease, if you end up treating these sites with local therapies, especially radiation therapy is the most common mode to treat these patients. There's other things we can do if they spread to the liver. We have line 90, we have surgery. But in the lung, it's most common to treat with SBRT or radiation therapy. And these patients, when we treat them aggressively, they have a long tumor-free survival. I mean that, a lot of these patients where technically they're not, curable, they do live a long time without evidence of cancer in many of our patients. So that's why at Norrin we're very aggressive, and we really try to, help our patients progress with or live without worrying about cancer as long as they can. And so this treatment here is again called stereotactic body radiation therapy. It's a high dose of radiation. It requires a lot of accuracy and a lot of planning with our dosimetrists, our physicists. Probably heard a little bit more about it during our lung session, but it's something that we very commonly do at Norton. And so I guess CT 3 months after the SBRT showed that it improved. There was a little bit of pneumonitis, it appears, but nothing significant. And it's something that just we see on the scan after our treatments quite often, but it doesn't really affect our patient's breathing. It usually disappears on its own. Sometimes you can get pneumonitis that does lead to breathing issues, but that's very rare. And usually, of course, with steroids, it goes away with that. And patients tolerate this treatment very, very well. They don't even know they got treated.
I think it's fair to say that most patients, if they're eligible, most patients will like the idea of just a few days of radiation treatment with a fairly low risk of side effects as compared to a thoracotomy and removal of a big chunk of their lung.
And so that concludes our GI section. Please join me in giving them a round of applause for their great work. And as you've seen all day, we are able to assemble these teams to take care of patients' unique needs. We look forward to expanding this program to other disease sites. We already have site-specific tumor boards that deal with gynecologic oncology, GU oncology, hematologic oncology, et cetera. But we look forward to expansion of that with you. I do want to just again mention Governor Nixon and the Hospital Foundation, Children's Hospital Foundation for supporting today. Again, thank our vendors. Karen and her team from CME, if we can give them a round of applause for all the support today. And then Daniel and our media services folks in the back, just a tremendous job. Thank you so much for being so seamless. It's never easy to have technology work, especially with this Zoom and this ambitious program and this crazy committee that wanted to do Zoom in, Zoom out, broadcast live, in person, everything. You all just said, let's try it. And you did a great job. And then finally, Lauren White really did all the work today. She's amazing. She's back in the back here. Let's give her a big round of applause. And we look forward to working with you all for the next year and building a great symposium next year. So thank you very much for today.